and this is a hybrid seminar, and I believe that we have a huge number of registrations for this, and many of you are still joining. My name is Mukta Sharma, and I work in the World Health Organization Indonesia Country Office. I'm the technical lead for antimicrobial resistance. And today we are very excited to bring to you the first presentation in Indonesia on the WHO AWaRe Antibiotic Book. This is part of the essential medicine list, and we are very, very happy to be sharing with you this resource, which will be launched by WHO in November, coming in the next month. So I'm extremely privileged to have with us today Ibu Anis Karnawati. Ibu Anis is the chair of Indonesia's Antimicrobial Resistance Committee, and she has been very kind to agree to moderate this session as well as to lead the discussion. We have interpretation available for this for this online seminar. If you want to choose Bahasa, please press on the Japanese language sign, and otherwise please press on English. The seminar is supposed to last a total of 90 minutes, and our speaker will be speaking for about 45 minutes, and then we will be noting down questions as they come. We will put them up in a PowerPoint after the presentation for our speaker to address, and then there will be a moderated discussion session. So without further ado, welcome everybody, and let me turn this over to our chair today, Ibu Anis. Ibu Anis, please.
Thank you, Ibu Mukta. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. My name is Anis Karuniawati, and I'm clinical microbiologist. And since last year, I have been appointed as the chairperson of AMR Control Committee in the Ministry of Health Indonesia. So I'm your moderator today for this online seminar with the title WHO AWaRe Essential Medicine List Antibiotic Book. WHO AWaRe stands for Access, Watch, and Reserve, classification of antibiotics for evaluation and monitoring of use, and it is a useful tool for monitoring antibiotic consumption, defining targets, and monitoring the effects of stewardship policies that aim to optimize antibiotic use and curb antimicrobial resistance. The AWaRe book has not been launched yet. We are very lucky to hear about the content of the book before this book is being launched. Soon, this book will also be translated into Indonesian. You will be hearing a presentation from our distinguished speaker, Dr. Benedict Hattner. So here I will read for you a short curriculum vitae of Dr. Benedict Hattner. So Dr. Benedict Hattner is the secretary of the expert committee on the selection and use of essential medicine and team lead essential medicine at the World Health Organization, a position he holds since March 2021. Dr. Benedict obtained his medical degree in Munich, Germany in 2001 and then moved to Switzerland. After training in internal medicine, he specialized in infectious diseases in Zurich. Between 2006 and 2021, he has been working at Geneva University Hospital, first in the Infection Control Department and then in the Division of Infectious Diseases since 2014 as attending physician. Between 2010 and 2012, he completed a research fellowship in Salt Lake City, where he obtained a master's degree in clinical research. Before joining WHO as staff, he became assistant professor at the Faculty Medicine of the University of Geneva in 2020, with his research focusing on appropriate use of antimicrobials and other medicine and the control of multi-drug resistant bacteria. Between 2017 and 2020, he had been working as part-time consultant with the Essential Medicine team at WHO. So please welcome Dr. Benedict Hartner. You have 45 minutes for your presentation. Please.
Thank you very much for the kind introduction. Good morning.
So I'm sorry, your voice is not yet here. So
okay, let me know when
can
it's
you manage
okay.
it?
I'm unmuted.
So you have already unmuted, but we cannot hear you.
Okay. Also okay, and should I wait until you fix the issue for the room? Probably, no. You let me know how I should proceed.
So please, you can start your presentation.
Okay.
I hope we can hear it.
Okay. Yeah, thank you very much for the kind introduction.
Thank
Good
you.
morning from Geneva. Good afternoon to Indonesia. I'm very pleased to be able to talk to you about the WHO AWaRe Antibiotic Book. The presentation is also going to outline you how it came to be, how it was developed, and starting with the development of AWaRe, and then leading to the development of the antibiotic book, which hopefully will be launched in the week before the World Antimicrobial Awareness Week. We will communicate the day as soon as we know it exactly. So I tried to share my screen. So, oops, yeah. And then I need to switch screens. Now it should be okay. I hope for you. Can you see my slides? Yes. Okay. Thanks, Mukta. Okay. The AWaRe Antibiotic Book. You see, this may not be the final cover, but I already put it on there. It's going to be a product that's going to be available in several formats. I will show you later. But before I go into the details of the AWaRe Antibiotic Book, I think it's important to talk about how the AWaRe classification came to be, and that is related to the antibiotics on the essential medicines list. And if I'm sure you are familiar with the concept, but just to remind you, I maybe put this here. That the essential medicines list is updated every 2 years by the Expert Committee on Selection and Use of Essential Medicines. The next expert committee meeting will happen in April next year. The first EML was published in 1977 with an EML specific for medicines for children published in 2007 and also updated every 2 years. And in the context of a WHO Global Action Plan on Antimicrobial Resistance in 2015, there has been intensive focus on the update review of antibiotics on the essential medicines list. So the WHO Essential Medicines list, as you know, are then used by countries to develop the national essential medicines list. If we look at the essential medicines list from 1977, there were 240 medicine and 16 of them were antibiotics, if we exclude anti-tuberculosis antibiotics. And what you can see, if you look at the antibiotics that are listed on the right-hand side, those with an asterisk are still on the EML in 2020. So most of them have remained relevant for human medicine. There have been 2 sulfonamides that have been removed, but overall, the antibiotics that were listed in 1977 are still essential antibiotics in 2022. And what is also important to mention is when that list was developed, the Director General at this time, Halfdan Mahler, said that the essential medicines list should not only provide a prioritization list for which medicines to procure, which should be available, but also that there should be adequate information on the properties, indication, and use of these medicines. And that is clearly where the AWaRe Antibiotic Book comes in. So now, what is the situation in 2021, the last update? 22nd essential medicines list, we have 39 antibiotics, so the number nearly has doubled, 36 on the EML for children. But if you look at the percentage of overall medicines, it remained about the same, about 8% of all essential medicines, making it among the largest groups of all medicine classes on the essential medicines list. And on the right-hand side, you see the classification, access, watch, reserve, and I'm going to talk a little more about that now. So the AWaRe classification of antibiotics, AWaRe is in the list, in the name of the antibiotic book. So it's a crucial foundation for the antibiotic book. So if we look historically, there have been many attempts to classify antibiotics. What we commonly use is the distinction between narrow and broad spectrum antibiotics. But this distinction has many limitations, not the least being that there is really no standardized definition. And you can argue a lot for each molecule, whether it should be broad spectrum, narrow spectrum, depending on whether you consider the activity against clinically relevant pathogens, or whether you take into account the activity against human microbiota, which may be just as important or even more important if we consider a transmission of resistance or Clostridium difficile infection. So clearly need to have better standardization. And that is where the AWaRe classification comes in. So initially, only antibiotics on the essential medicines list were classified into one of the three categories. And you see the color scheme. The color scheme uses a traffic light approach, showing for which antibiotics you need to pay more attention with regard to antibiotic stewardship and assuring appropriate use. It's clear that even green access antibiotics should not be used inappropriately. And at the same time, even though we have a reserve category that's in red, it doesn't mean that these antibiotics should not be available and not be used in patients who need them. So that's just as a general comment, antibiotics that are considered essential, that are on the essential medicines list, should be accessible and affordable for those who need them. And we know also that in many settings, this is not the case, especially when it comes to the reserve antibiotics. So what are these different classes? Maybe I should have started with that. So access and watch were first and second choices for many common infectious syndromes. And I show you later how this was derived. And the differentiation between watch and access is the impact on resistance, with watch antibiotics having a higher propensity to select antimicrobial resistance, maybe having also a less good safety profile, and access antibiotics having lower resistance potential. So a classic example of an access antibiotic would, for example, be amoxicillin, while antibiotics like fluoroquinolones or third-generation cephalosporins would be watch. And then there's this third category, which is called reserved, that are last resort option against multi-drug resistant organisms. So, for example, colistin would fall in this category. So how were the first and second choice options defined? And this is relevant for the antimicrobial book, because the AWaRe Antibiotic Book recommends antibiotic first and second choice antibiotic options based on the antibiotics that are listed for these indications on the WHO essential medicines list. And how were these first and second choice antibiotics identified? This was based on an extensive review of many different infectious syndromes. And you see on the left that this was work started in 2017, but it continued in 2019, 2021. So this is an ongoing effort. And you see that the type of infections are very variable, though they go from infections that usually do not require antibiotic treatment, like most upper respiratory tract infections, to dental infection, to very severe infections like sepsis or meningitis. So you have a whole range of different infections. With the exception of surgical prophylaxis, most are for the treatment, or all are for the treatment of infections and not prophylaxis. But surgical prophylaxis was also considered because it's a very frequent cause of antibiotic use, as also, for example, the dental infections, why they have, for example, quite a prominent chapter in the AWaRe Antibiotic Book. Most are on community-acquired infections. So they may be infections seen in primary healthcare or infections being in the hospital setting, like sepsis or severe community-acquired pneumonia. But it doesn't focus on hospital-acquired infections. And the reason for that is twofold. One, the evidence base for the hospital-acquired infections often lower. And second, there's clearly much more variability between settings, even within a country, in terms of the relevant pathogens and their resistance pattern. Most are empiric choices. So it is not if you have a specific pathogen identified. So it would be a patient presenting with community-acquired pneumonia, not a patient with pneumococcal pneumonia. But there are some exceptions, and these concern mostly the sexually transmitted diseases, where we have some specific pathogens like chlamydia, gonorrhea, syphilis, trichomoniasis, or for the gastrointestinal infections like cholera, shigellosis, or Clostridium difficile. But the rest is pathogen before identification of a pathogen. It is based on a review of systematic reviews and guidelines. You can imagine that doing this kind of work for over 30 infections is a lot of work. That's why systematic reviews were analyzed. So a large evidence base is available. The evidence base has limitations. Not all studies are high quality. And unfortunately, also lower middle income countries and studies from lower middle income countries are underrepresented in the evidence base. And that's something that definitely needs to be addressed better in the future. Though this is a different list of infections, if you look at the global burden of infectious diseases, I think it's obvious that there was a need to cover these infections because, as you know, WHO has very strong guidelines for diseases like tuberculosis, malaria, some other infections. There was, especially for adults, there was guidance missing for respiratory tract infections, some of the enteric infections, meningitis, etc., or urinary tract infections. So I think these recommendations on which the WHO AWaRe Antibiotic Book is based fill an important gap in what really is the burden of infectious diseases in most countries. So based on the systematic review and the analysis of the guidelines, first and second choice antibiotics were defined for the different infections. And what is very important is that the first criterion was always efficacy. So the most effective and safe antibiotic would be the first choice. And also specifically infections were included that usually do not need antibiotic therapy, such as the upper respiratory tract infections, so otitis media or pharyngitis. In many, many cases, no antibiotics would be the first choice, just symptomatic treatment. And we also know that in many settings, these infections are usually treated with antibiotics. And that's something the antibiotic book clearly also focuses on, to indicate situations when no antibiotics are actually the preferred approach. If there is a need to prescribe antibiotics, for example, if the infection is very severe, or if there are certain risk factors, then whenever possible, an access antibiotic would be recommended, for example, amoxicillin. Second choice could be an access or could be a watch antibiotic, depending on the evidence base. And then you have very rare situations where the first choice would be a watch antibiotic, because among the access antibiotics, there was no antibiotic fulfilling the criteria for efficacy that would make it a first choice or would justify its listing as a first choice. So this was done for all the syndromes I showed you before, defining first and second choice. Sometimes there may be more than one first choice or more than one second choice antibiotic. So I do not want you to look too in detail at how this worked, but just that you know who came up with these recommendations. So this was a WHO EML antimicrobial working group that analyzed the reviews and the guidelines, makes recommendations, and then the final decision or recommendation which antibiotic to include on the EML as first and second choice by the expert committee. So the expert committee that does the entire EML every 2 years. And then the final decision is not even the expert committee, it is the Director General of WHO who recommends first and second choice for each option, usually just accepting the recommendation by the expert. So this was the initial AWaRe classification. Again, don't spend too much time looking at it. It was a little confusing. Sometimes different molecules were mentioned, sometimes classes. Again, this has been cleaned up. So this is the current situation. I also said initially only antibiotics and the essential medicines were classified. Now the idea is really to classify all antibiotics that are available. So this is the 2019 version. 2021 did not change much, except that cefiderocol was listed in the reserve. You see, it corresponds a little bit what you expect. You have most antibiotics in the access, fewer in the watch, and then even fewer in the reserve list. Now, always specific molecules are listed. Usually, classes are in the same category. Sometimes that is not the case. For example, you may have meropenem here in watch, but an oral carbapenem, for example, as a reserve. And there was also introduction of a not recommended group. And this is actually quite important in some countries where antibiotic combinations that really have no good justifications are frequently used. Could imagine, for example, a cephalosporin with a fluoroquinolone. So these would fall into the not recommended antibiotics. If you're interested in how antibiotics are classified, you can go to the WHO website. I have to admit, it's not always easy to find, but when you enter WHO 2021 AWaRe classification in the search engine, usually you should find it among the first hits, and there you have all the different antibiotics, the classes, ATC codes, categories, and whether these antibiotics are on the WHO EML or not. It's clear that there may be certain gaps. Some antibiotics may be available so only in certain countries or regions. So this list is regularly updated, and there are also potentially always adjustments of the definition of the different categories. So access group, 20 antibiotics. So these are really the most important ones. Amoxicillin clavulanic acid is also in that group, although some people say it should be watch. What else? You have nitrofurantoin for lower urinary tract infections, clindamycin, but mostly it's narrow spectrum, even though I said the term is not useful, but narrow spectrum beta-lactams. And these, whenever possible, and when antibiotics are indicated, should be the first choice, and they can be the first choice, even in most settings with relatively high resistance, because the key pathogens of the most common infections, with a few exceptions, remain susceptible. For example, if you look at urinary tract infections, nitrofurantoin really remains a good option in most settings against most enterobacterales, even when there's a high level of resistance to other agents. The watch group antibiotics, slightly smaller, more resistance, fluoroquinolones, macrolides, third generation cephalosporins, carbapenems also in that group. Again, this is an issue of discussion. Some people say it should be reserved. There's some overlap with the critically important for antibiotics for the animals, and I will show you later. Should be important for, yeah.
Benedict, could you slow down a little bit? It'll help the interpreter as well.
Okay, sorry. Yes, I've had I think already 3 or 4 cups of coffee. That may be the effect. So. Okay, I slow down. Okay, here these are the watch antibiotics. So you see it's broader spectrum antibiotics, macrolides, fluoroquinolones. I just looked at a paper from Indonesia, and I saw, for example, that ciprofloxacin use, for example, is I think relatively high in your country. So that would be, for example, an antibiotic. Should be an effort to reduce the use. And then there's a reserve antibiotics. Currently, there are 8 last resort antibiotics. The definition remains a little bit vague in the sense that it is mainly defined as last resort options active against multi-drug resistant bacteria, highlighting the carbapenem resistant gram-negative bacteria, such as carbapenemase producing Enterobacterales. But you see that it's not entirely consistent because you also have linezolid in that list. And I think at the time, the thinking was it would be good to have that oral option for gram-positive organisms in the reserve. And also, we know that linezolid and other antibiotics of that class are unfortunately overused in many settings. But you see that there are older options like colistin and fosfomycin, but you also have newer antibiotics such as ceftazidime, avibactam, cefiderocol, meropenem, verbabactam. Unfortunately, relatively few options against metallobeta-lactamase producing carbapenemase, but that's just because there are not many options available for now. Now, this is a list here. You also have plasmomycin. It was listed at the time with the idea to make it available. So this is a newer generation aminoglycoside, but it's not currently marketed as far as we know anywhere. The reserve antibiotics are very important, and both because there's not sufficient access and because if they are available, they absolutely need to be used cautiously in order not to further create resistance. That is why the reserve antibiotics are also specifically included in the AWaRe Antibiotic Book. So there are chapters on each of the reserve antibiotics. There is, unfortunately, a very big limitation, and this is due to the fact that there are very few studies really looking at the efficacy of these antibiotics against multi-drug resistant gram-negative bacteria, because usually they are approved in studies that do not specifically look at resistant infections, but we tried nevertheless to give some guidance. Hopefully, this will change in the future. You see that the group of reserve antibiotics is much larger than these 8. You have many different, but I would say that there are really few, if any, or at least very rare indications to use these. They're never listed as first or second option, but obviously that's also part of the fact that we never considered specifically settings with high resistance like nosocomial infections. In certain situations, empiric use, meaning treatment without having a pathogen identified, may be appropriate. Not recommended. I'm not going to stay long on it. I mentioned it. There's quite a lot of use. Obviously, there are fixed dose combinations that are very useful. Usually that would be, for example, amoxicillin and clavulanic acid. So not really 2 antibiotics, but an antibiotic and a beta-lactamase inhibitor, and that's by far the most frequent. But if you look at the worldwide market, there are quite a few where really it is difficult to imagine an indication except to further antibiotic resistance like cephalosporin and oxazolidine. So this is a bit contrary to other medicines. You know that, for example, for antihypertensive medicines, now there's a strong recognition that these fixed dose combinations are very useful. For antibiotics, that's the contrary. Generally, if there's not a very good rationale, they should be avoided. Most of the ones that are available are not approved by the US FDA and are not compatible with the essential medicines list. So now I told you a lot about access and watch and how they impact the resistance differently. And you may argue, yes, but on what evidence base? And the evidence base, unfortunately, is not very strong, but there was a large systematic review recently published in Clinical Microbiology Infection looking at the impact of colonization or infection with multi-drug resistant organisms by the different AWaRe classes. And the studies have many potential methodologic problems, differences in how antibiotic exposure is defined, infection and colonization is not the same thing, etc., etc. But still, what you can see on the right side is that any antibiotic exposure, even access antibiotics, increases the likelihood of being colonized or infected with a resistant organism. So whenever there is no need for antibiotic, it shouldn't be given. And then, in general, watch antibiotics are associated with a higher risk than access antibiotics, and reserve antibiotics also have a higher risk than maybe watch and access. So this shows that the AWaRe classification has some basis and is not just based on expert opinion. There is the overlap with the critically important antimicrobials of list. So a One Health approach is something that now is mandatory if you want to control antimicrobial resistance. And it is, I find, nearly a little bit embarrassing that actually for the animals, there was a list way before there was a list of antibiotic prioritization by resistance for the humans. So this is since 2005, WHO, together with the World Food Programme and the Organization for Animal Health, classifies antibiotics that are used in animals according to their importance to human health. There are currently efforts to try to align it more closely also with the AWaRe classification, because I think there's a risk for creating confusion. If you look now, yes, it's mostly reserve and watch antibiotics that have the highest or high priority of these antibiotics, but there are even some access antibiotics. So this is something that's currently undergoing discussion. So what to do with AWaRe? You know, classically, we look at overall antibiotic use based on something like defined daily doses per 1,000 inhabitants per day, and you have a very large variations between countries. But it's really difficult, if I go back to the slide, to know where the level of appropriate use is. Is it more on the right side, more on the left side? May depend a little bit also on the population structure you have. Do you have a lot of children, a lot of very old people, etc.? But in general, it is probably safe to say that the level of use is rather on the lower side, given that the mortality through infectious diseases is not extreme, even in countries that have, or there's no signal that it's associated with an increased mortality in countries that have a lower antibiotic use. But the AWaRe framework offers a possibility to have another indicator, and that is endorsed by WHO, and that says that access antibiotics should be at least 60% of overall antibiotic consumption. That's applicable mostly to primary healthcare because the vast majority of antibiotic use occurs in the primary healthcare. In the hospital setting, there has been no specific indicator developed or validated or published. Probably, in general, there is some justification to use more watch, even a little bit of reserve, which essentially is not used in the outpatients. But if I remember correctly, I think Indonesia reaches this target with 69%, but this is not a reason to say everything is okay, because the 60% target is actually quite conservative. You see in Europe here on the left side that many countries meet the target, but there are quite a lot of countries also who do not meet 60% access target. And why do I say it's conservative? Because if you look based on the review that was done and on the AWaRe Antibiotic Book, what are really the types of antibiotic needed to treat these common infections? So it's either no antibiotic, or in most cases, it's an access antibiotic. So 60% is a relatively low level if you have really good use, and there are countries that get to that level. It's probably more 80, 90%. But for now, there is no, the target remains endorsed by WHO is 60%, but it doesn't mean that it shouldn't go even higher. If you look at the worldwide situation, there has been a massive increase in the use of watch antibiotics between 2000 and 2015. And that is more marked in lower and middle income countries than in high income countries. And if you look at the percentage of countries meeting the 60% access target until 2015, at least, it had actually gone down rather than increased. Just a word of caution, percentage is not the only way you should look at it. If you compare country A to country B, you may be tempted to say country A, 50% watch use is doing worse than country B with 25%. But then obviously, if you look at the overall antibiotic use, the situation is inverse. So just a word of caution, a single indicator can capture the whole complexity. And I was very happy also to see this paper published recently in the Lancet Regional Health Southeast Asia about antibiotic use in Indonesia, looking at all kinds of different indicators. And obviously, one of the best is having an indicator specific for indications where you can then look at appropriateness in different settings, etc. And I would say nearly all countries, there's a lot of work to do. Even countries that have fulfill the access indicator and have maybe a relatively low overall antibiotic use, there is overuse of antibiotics or inappropriate use of antibiotics. Some countries have adopted AWaRe, for example, the UK, reclassifying amoxicillin and clavulanic acid or the carbapenems. Something that can be done. It's always a risk, but then there's a difficulty for comparing data. I'm going to jump because I know I'm a little bit behind. So the issue is that all I talk to you about now is which antibiotics to use for which infection. And that's also listed on the electronic EML. You will find amoxicillin, and on the right side, you see first choice for these different infections. But what about how to make the diagnosis for such an infection? What dose do I give? How long do I treat with that antibiotic? There's no information available here. And this is where the WHO AWaRe Antibiotic Book comes in. And you see here as an example, the infographics for community-acquired pneumonia. And there's going to be a book with many chapters on each infection. So it's going to be over 400 pages, outlining not only the treatment choices, but also the epidemiology, which pathogens, the differential diagnosis, giving you not only the antibiotic, but also how much to give, for how long to give it for, and many other information. And then the essentials of this information are available in infographics, always for adults and children. And then, at least for now, for the English version, there's also going to be a smartphone application that has this information. And there's also going to be a web version. So you will be able to access this information in many different ways. Why the need for it? Because we know that many countries do not have local or national antibiotic treatment guidelines. This example was published in the bulletin of WHO this year, looking at 55 African Union countries. And as you can see, over the time from 2001 to 2018, 35 of the 55 countries had no guidelines identified. A lot of variation in the guidelines that were available, none developed according to great methodology, none antibiotic selection based on local epidemiology of antibiotic resistance. So clearly a gap. WHO has a lot of very high quality guidelines, and I'm showing you here just two, one for sexually transmitted diseases or for tuberculosis. It's clear that whenever there were guidelines by WHO, the antibiotic book is tightly aligned with these guidelines. So it's the same recommendation as in the WHO guidelines. But as I mentioned, the issue is that for many frequent infections, WHO didn't have guidelines. It's important also maybe that I mentioned that the AWaRe Antibiotic Book is not a formal WHO guideline, it's a guidance document, because it didn't follow exactly the same methodology, partly because it's also not possible given the large number of infections, and the evidence base, for example, for things like dosage, duration is often relatively weak. There was actually in 2001 a model prescribing information for the essential medicines list. It has been used in the past, but outlining not only the treatment, but also giving some background information. So in a way, this is an update, but with a more systematic, evidence-based development. So I mentioned, it gives you the definition, epidemiology, diagnosis, importantly, a link to the essential diagnostics list, giving the standard dose, for now, not taking into account renal dosing, but pediatric dosing by weight band, duration favoring, in general, shorter duration, because now there's quite good evidence that for most infections, shorter treatment is just as effective as longer one and potentially associated with less resistance, based on review of literature, guidelines, expert input. And we have also the chapters on the reserve antibiotics. And again, I mentioned it because it's so important, a no antibiotic strategy whenever that's adequate. And then it has also some general chapters on good antibiotic prescribing regarding, for example, step down to oral therapy, etc. This is an example of the infographics for otitis media. I had shown the one for pneumonia before. This is just the second page where you have the treatment. You see, you have also proposals for symptomatic treatment, again with weight band, and then the antibiotics, if they're indicated, are color-coded, green for access, yellow for watch, red for reserve. And this again for all the 35 symptoms. Clearly, there are issues where we will need feedback from countries like Indonesia, how it should be adapted in the future. How do we take into account different prevalence of resistance across settings? As I mentioned, probably for most infections, at least those encountered in the outpatient setting, it doesn't play such a big role. But for example, for some of the enteric infections or for severe urinary tract infections or intra-abdominal infections, may very well play a role. How to take into account different diagnostic capacities across setting. Again, I think this is something that mostly concerns the hospital. In the community setting, diagnostics often is of limited utility. And then the big issue always how to adapt evidence from high income countries to the low middle income setting. And this is just an example. If you look at the class data, at the E. coli from blood isolates, very high resistance to third generation cephalosporins and fluoroquinolones. But the issue is always how representative are these data. There's certainly a selection bias. Most severe patients maybe have been pre-treated with antibiotics, etc. But it's clear that in such a situation, if you just look at the resistance data, how would you treat a patient who has a severe urinary tract infection, neither ciprofloxacin nor ceftriaxone? If you just take into account this data, would be adequate. So that's something that needs to be resolved, and part of it is also that we need better data, patient-specific data. So the next step, so the launch is probably going to happen on the 14th of November. We're just trying to confirm this, including the smartphone application. We're working on an implementation plan. Very happy also to work with you in Indonesia to see very enthusiastic that you're early adopters of the AWaRe Antibiotic books. We are obviously planning also updates of the book based on the feedback we received. We had a public consultation phase where we received a lot of comments. We're just about to publish those. But clearly, once it's widely used, we want to have feedback from you. What do we need to change? What needs to be added? What needs to be deleted, etc. AWaRe is going to be updated. There are probably going to be some changes how we define reserve to make it more evident and more, let's say, less ambiguous how it's defined. There's clearly a need for new indicators for antibiotic use, which could be based on the AWaRe Antibiotic Book. We're closely working with the colleagues from the AMR division here at WHO. So there's a lot of work to be done. We are aware that the antibiotic book alone will not change antibiotic prescribing, but we feel it's an important element to improve antibiotic use. And with that, I want to conclude, and I just want to thank the numerous people who have spent countless hours in developing and doing this book. We've been working on it now for 3-4 years, and I'm very happy that despite COVID-19, we were able to advance it that far. And specifically, I want to thank Veronica Sunny-Kelly, a consultant who works with us, and Mike Charland, who is chair of the antimicrobial working group, who've done a lot of work for that. And then also the funders who funded this work. Thank you very much. And I'm available for questions. I hope I didn't talk too fast in the end, but I have doubts.
Thank you, Dr. Benedict. So next we will have a discussion session, and there are some questions already. Would you please share the, yes. So this is the first 3 questions. Dr. Benedict, how often do we need to regulate the AWaRe list? So maybe you can answer it directly.
Yeah. So the AWaRe list is updated every 2 years when the essential medicines list is updated. It's clear that in the beginning there were quite big changes, because it's always when you put out something in the beginning, you realize that certain things work, other things don't work. So there are going to be changes. There are going to be changes regarding reserves. There are going to be maybe new antibiotics added. But I think the more time goes by, the more stable the list would be. But I think for now, it should be updated every 2 years with when a new WHO AWaRe list comes out. And clearly, it would have been preferable to come up with the perfect solution right away. But in real life, that is not the case, or never the case. So we apologize, and if sometimes these changes create confusion, but the goal is really to make it to create less confusion, and also, as I showed, to align the different products, because for now there's not only the critically important antimicrobial list, but there's also the OIE, it's now called World Organization of Animal Health. There's a different list and another list for antibiotics for animals. They all have different terminology. So I think if we want to implement a One Health approach, these lists and products should be more aligned.
Thank you. The second question. In Indonesia, based on the recommendation from Ministry of Health, meropenem is classified as reserve antibiotic. But in the WHO, I think it is in the watch classification. So which one we should follow? So actually, the question is, can we actually change the classification? It's based on the local consideration. Please, Dr. Benedict.
Thank you very much. This is a very good question, and that's a question that regularly comes up. And as I've shown, some countries in Europe also have adopted the list, putting meropenem in the reserve category. And I think France, for example, did the same. So it is perfectly possible to adapt it locally, as long as then, you know, the data reported to WHO, they should be comparable, because otherwise you would kind of also punish yourself, because your reserve antibiotics use would be much higher than in other settings. So that's the one thing. Why is meropenem or imipenem or the carbapenems, why are they not in reserve? And this has to do with the fact that there may be unintended consequences of putting it into reserve. Unfortunately, we know that there are many settings where extended spectrum beta-lactamase producing Enterobacterialis are extremely prevalent, right? Very, very frequent, and where carbapenems really must be available to treat severe infections with these organisms. It's clear that there is also important overuse of carbapenems, but this is balanced between access and avoiding overuse. But this is a discussion that regularly comes up. I still think carbapenems are a bit different from these other agents, ceftazidime, avibactam, for example, or the polymyxins, because there may be situations where they're first choice. You know, you could think of some meningitis. I think it's listed, for example, neonatal. So there are situations, I think, more frequent where carbapenems are indicated, and with the current epidemiology of ESBL. But again, if you talk to a lot of different people, you will have many probably saying carbapenems should be reserved or not reserved. So that's something that's going on. There's discussion maybe to have two different watch groups, to have a watch plus, where the meropenem and the carbapenems could be put in. But again, this is something that discussion is going on.
Yes, thank you. So I think you have answered the question. So the next question, would you please explain the reason why is ceftalosan tazobactam not considered as reserve group on EML? I think because this question arises because this drug is a new drug in Indonesia.
Yeah. There are two issues, right? One is the classification as reserve or not reserve, and it is classified as reserve, but it is not on the essential medicines list. So it's a reserve antibiotic, but not on the EML. So why is it not on the EML? Unfortunately, I can't remember. It was evaluated, but at that time, it was felt that it didn't have the same priority as the other agents for the treatment of multi-drug resistant gram-negative. It's clear that there may be a role for, you know, certain Pseudomonas infections, etc. But the expert committee at the time felt that it didn't fulfill these criteria. May change in the future. You know that anybody is also free to submit applications for consideration by the expert committee. So this may change in the future, but at the time was felt it was not fulfilling sufficiently the criteria as essential medicine, but it is a reserve antibiotic.
Okay, thank you. And the next question, there are still some questions, I think. Yeah. So this is a long question. Regarding antibiotic categorization, so according to AWaRe, what is the strategy to suppress global use, especially the reserve group, if there is no adequate data related to the needs of a country? This is because the pharmaceutical industry in production and distribution uses market demand data, while in the field, many uses are not in accordance with the provisions. More about the source text. No, I don't,
Okay.
yeah.
Yeah.
So this is the...
Okay, I tried to answer according to, I'm not sure I understand it correctly, but if you look globally, the reserve use is probably not the biggest issue. Why not? Because reserve antibiotics are not available in many settings, and they're not available in the settings that probably most need them. So many low middle income countries that have a high burden of multi-drug resistant organisms do not have access to reserve. There's been an analysis recently of comparing the WHO essential medicines list to national essential medicines list for the antibiotics, and where there was the biggest gap in the sense that antibiotics were missing on the national list that are on the WHO list was the reserve category. So that's fully acknowledged as a problem. Why is that the case? These newer antibiotics are more expensive, much more expensive than older antibiotics. Probably also limited interest by pharmaceutical industry. Microbiologic capacities may also be an issue. But that's something that WHO tries to address. There's this whole secure project together also with GARD-P of trying to make this antibiotic available also in low middle income countries. But clearly, this needs to be associated with other measures. And I think one of the key issues is you can't talk about antibiotic stewardship in hospitals, and that's where the reserve antibiotics are going to be used, without talking about infection control. Because if you do not inhibit transmission of multi-drug resistant organisms, you can do all the want with regard to good antibiotic use, you will have a problem. So this is one, infection control, and then obviously also assuring that these antibiotics are used appropriately. In an ideal world, and we know this is not always possible, you would then have a microbiologic confirmation, and then if you have an identification of a susceptible organism, it should be stopped, etc. So this needs to be a priority. If we look globally with regard to what are the problems of inadequate use, it's one, overuse of antibiotics when none are needed. And that's clear. That's even in countries that have a very low level of antibiotic use. If you just look at the defined daily doses per 1,000 inhabitants per day, if you look at a country, some countries in Europe that have about, I think, 3 to 4 times lower use than other countries, even there's overuse of antibiotics. And this is mostly for upper respiratory tract infections. So a lot of sore throat, COVID, otitis media, sinusitis is treated with antibiotics when it shouldn't be. So that should really be one of the key priorities for all countries, to try to avoid this completely unnecessary use. It may be very complex. Many countries, self-medication is an issue. You can obtain antibiotics without prescription, over the counter, etc. So completely acknowledging that it's a complex issue to resolve, but this is important, and I think that's where the antibiotic book will go. And then the second most important issue is the overuse of the watch antibiotics, like the fluoroquinolones, like the macrolides, like the third generation cephalosporins. In many countries, there are the majority of treatments. So exceptions, because we have the 60% access targets, but there are quite a few where really they're massively overused. And we know that these antibiotics contribute to more resistance. So whenever possible, these should be replaced with access antibiotics, or I think quite often also with no antibiotic prescription. I talked a lot, but it was a complex and long question. I hope I answered it somehow.
Yeah, terima kasih. Thank you. So the next question. Yeah. So while waiting, I just want to inform you, Dr. Benedict, that Indonesia has already the guideline for antibiotic treatment as a national guideline, and this is published by the MOH, and it is also there is also the classification of AWaRe there. Yeah.
Very good.
And we hope that this guideline will, as a what you call, as a reference for the hospital to make their own guideline. Yeah. So this is the next question. Can you explain more about tigecycline position, since I cannot find in AWaRe list?
So tigecycline is a reserve antibiotic because it's active against some of the multi-drug resistant gram negatives, but it is not on the essential medicines list. And why is it not on the essential medicines list? Because the antibiotics or any medicine that is on the essential medicines list is selected with regard to efficacy and safety. And there are now quite a few systematic reviews and meta-analysis that show that at least for severe infections, there is potentially higher mortality with tigecycline than with other agents. So it's less effective than other options. And this is the reason why it's not on the essential medicines list. It can have certain indications, but it should not be the first choice since you have better alternatives.
Okay, thank you. And the next from Shiva Badrin. Thank you for the great presentation. I'm Shiva, CEO of Bijayuk ID, the social movement to increase awareness for antibiotic resistance. One of the issues is in Indonesia, the unavailable microbiology lab in many hospitals. Some in teaching hospital has already regularly antimicrobial report released annually. Can I clarify that the local report is more important to follow? How we balance between local report and the book?
Thank you very much. It's a very good question, and it's a question that's difficult to answer. The problem is that some of the local antibiograms are quite difficult to interpret. So what you have to distinguish is patients coming into a hospital from the community with an infection from patients who develop an infection acquired in the hospital. And the hospital-acquired infections are clearly those at much higher risk of being caused by an antibiotic-resistant bacterium. Unfortunately, many hospital antibiograms do not really differentiate these two very, very different domains because you need more data to be able to do it. You need to know if the sample is obtained from a community-acquired infection, even if the patient is then treated in the hospital or if it's a hospital-acquired infection. So I think to really use local antibiogram data, you need to have more information. You need to know some characteristics of where the samples were obtained from the community or hospital acquired. What was the type of infection? Was it just a urinary tract infection, maybe even asymptomatic bacteria, or was it a blood culture positive in the course of a septic shock? Again, I think for most of the community-acquired infections, probably the local hospital antibiogram is not as informative as national surveillance general of knowing the prevalence of resistance in key pathogens. If we talk about hospital-acquired infections, for example, patients in the intensive care units who then develop sepsis in the context of ventilator-associated pneumonia, there clearly you would like to have your local microbiology data. And we know that the absence of microbiology laboratories is a crucial problem. And it's all the more important if now we say we want to increase access to the reserve antibiotics, because to use them correctly, you should really then be able to tell, okay, this patient is at least colonized or has an infection by one of these pathogens that needs such a treatment. If you don't have it, then you end up treating a lot of patients with reserve antibiotic, and then it's just a matter of time until you have resistance to these agents. So I unfortunately don't have the easy solution. I think for the hospital, microbiologic laboratory capacity is key to use antibiotic appropriately. The antibiogram have to be careful. You really have to have very detailed data to see how it can be used. And probably more important for the hospital-acquired infection than for the community-acquired infection.
Okay, yeah. So Yeah, so it is our problem, actually. So we usually, when a patient come to our hospital, they are already treated with antibiotic. So that's why once we got the specimen in the emergency unit or in the polyclinic, so in the when the patient admitted, where the patient admitted, and usually it is not really maybe not really the cause of infection. It is already changed. Yeah. So your the answer of this is that for the definite therapy for healthcare associated infection or nosocomial infections, microbiology is in the place, right? To
Yes, yeah,
give the definite treatment.
yeah,
Yes,
yeah.
thank you. The next question. What do you think about the use of prophylactic antibiotics before surgery?
So thank you very much for that question, because one antibiotic, surgical antibiotic prophylaxis is covered in the AWaRe Antibiotic Book. And second, because it's a frequent reason of inappropriate antibiotic use. So the indication for antibiotic prophylaxis depends on the type of surgery, classification, contaminated, clean surgery, etc. So not all kinds of intervention need treatments, and there are clearly outlined, clear guidelines on when it's indicated or not. The key issue with regard to antibiotic prophylaxis is A, the selection of the correct antibiotic, but B, and this is a problem in most settings, the duration of the antibiotic prophylaxis. There is now really, really, really good data that in general, a single dose or at least not more than 24 hours of antibiotic treatment after surgery is sufficient to prevent surgical site infection, and that longer treatment is associated with antimicrobial resistance and other adverse effects. So the key for a hospital looking at surgical prophylaxis is, on the one hand, making sure that the right patients receive the right antibiotic prophylaxis. And that timing, for example, is also important, half an hour, 1 hour before surgery, before the incision, but to make sure that the surgical prophylaxis is not continued unnecessarily. Because very often patients receive then 3, 4, 5 days or even longer of prophylaxis. That's not prophylaxis anymore. That's treatment, but treatment of what? So really good evidence that it needs to be shortened. So every hospital should have, where surgery is performed, should have clear surgical prophylaxis guidelines. And again, it is covered in the AWaRe Antibiotic Book. And then the issue of what to do with patients who are colonized by multi-drug resistant organisms, that is actually quite difficult because the evidence base is so poor. Again, I don't think we can go into details here. It depends what the type of surgery is, what the type of organism is. In certain instances, for very high-risk surgery, you may need to adapt the treatment if you know, for example, that the patient is carrier of a carbapenem or an extended spectrum beta-lactamase producing enterobacterials, and goes on intervention like liver transplantation or a very major surgery. But these are the exceptions. In general, if an antibiotic is indicated, 1 dose, like maximum 24 hours, is the key that needs to be looked at from an antibiotic stewardship perspective. Same is true, by the way, for dental infections, right? Way too much antibiotic use for dental infections. I mentioned that the dental chapter is quite extensive because it clearly outlines also when are antibiotics indicated and when do antibiotics have no role.
Thank you. So next, is there any participant wants to ask directly? Yeah, Ibu Fitri, please. So Bu Fitri is here.
Take. Okay. Thank you so much. Good evening, good afternoon. Good afternoon, sir. I am Fitriana Hidayah. I am a pharmacist from Cipto Mangunkusumo Hospital, Jakarta, the IBC and EMR Control Committee. There are two questions that I want to ask for you. The first one is, can healthcare facilities adapt our category according to the local job pattern in the hospital? Example, antibiotic A from WHO is on a watch category, but the result of the antibiogram in the hospital are high, so we change the category raised to the reserve. Can we change the category of that WHO category? And the second one, can AWaRe be implemented in the community? If so, are there any example of practice in the community so we can learn about that? Thank you so much.
Thank you very much for these important questions. So the question number one is, can the AWaRe classification be adapted for an individual hospital? Though I think there are two answers to that. One is yes, of course, it can be adapted. It's up to you. We want that this tool is useful for you. And if you think that in your setting, it's important to reclassify certain antibiotics, you can do that. The only risk I see is that it may create confusion. What we a bit, on the other hand, want to avoid is that each hospital has a different categorization. Maybe if you could think about introducing different, you keeping the categories, but then maybe adding something to make it clear that there's restricted use in the hospital. But adaptation is possible. There's just a caveat that you create confusion if you have doctors moving across facilities, and in general, to have a somewhat consistent framework, at least on the country level, is not a bad thing, right? But you can adapt. Then for the community setting, how to use the AWaRe classification, is that correct? The second question? Yeah, okay.
Yeah.
Several issues with that. I think the AWaRe classification, we always talk about access, watch, and reserve, but there's also the not recommended category. I don't know how big a problem that is in Indonesia. It's a problem, for example, in India. For example, these antibiotics in the not recommended category, in a way, they should not even be available, right? They should not be available for use if they are not recommended, because there's no indication and they just contribute to resistance. Otherwise, I think AWaRe can be useful for monitoring antibiotic use, in the sense that we know, as I said several times now, that the access category needs to be the most prominent category for treatment of infections, just because these are the most safe and effective antibiotics for the treatment of infections. So if too many watch antibiotics are used, if the watch category is too large, there really needs to be an education, information of prescribers that either know antibiotics or access antibiotics are the correct antibiotics. Though some countries have also used some kind of restriction programs. It's not always feasible, depends a lot on the healthcare system. But for example, in some high-income countries like Australia, if you want to prescribe a fluoroquinolone, you have to go through a certain system to be able to do it. I'm not saying this is possible in most countries, but some of the watch antibiotics may need to be limited in some way, or may make it more difficult to prescribe them. I hope that answers the question.
Yeah, it's okay. Thank you. Yeah. So, any other question? No. Yeah. So we have still more time. So about 14 minutes. Is there any other question? So while waiting, my question for you, Dr. Benedict. So for example, gonorrhea. So the treatment of gonorrhea is also based on symptoms. But of course, we have to know the effectivity of these drugs, because stated in the new book that if there is a failure, then you have to change the treatment. And when the specimen should be cultured and to know the antibiotic susceptibility of gonorrhea, do we have to do a survey, and how often this survey should be done?
It's a very good question, and I don't want to say anything stupid because there are WHO guidelines on gonorrhea, and I could now say something I think that turns out not to be right. But I'm just looking it up because WHO defined it. So in general, surveillance for gonorrhea is probably not done as much as it should be, because it's, yeah, you know that better than I do as a microbiologist, it's not easy. It needs special media to culture gonorrhea. But if you do not have a culture, you will not have an idea about the resistance profile. So in some countries, it's recommended that, for example, for any gonorrhea, there is a culture obtained just to have the surveillance data. I realize that this may not always be possible. I can try to look at the the latest WHO guidelines. Again, I don't want to say anything that's not correct.
But Benedict,
but
actually, I can help you on this because
Yeah.
I come from the STI world.
Yeah.
So the WHO guidelines are saying that if molecular diagnostics are available, the issue with culture is that it can take so long in so many settings, and we are losing patients, while the culture is happening. So we are supporting in the WHO guidelines the need for doing molecular diagnostics. And in this case, the use of the NAT has also been proposed. WHO recognizes that people cannot always do culture. And that is why, while that is the first option, that you actually culture it, we are also recognizing that that is not always possible. So just to answer your question, Ibu Anis, the first line is do the diagnostic if possible using molecular rapid diagnostics. Because if you start using other forms of culture, often there's a risk that you lose the patient. These are often stigmatized patients, people who have high-risk behaviors, maybe sex workers, maybe men who have sex with men. So the idea is to be able to diagnose very quickly, and if not possible, the risk is not to lose the patient. Then we use the symptomatic treatment as it were. So if possible, always do molecular. If not, then go ahead and use the new treatment guidelines, which have taken into account the fact that there is significant resistance, and they have updated the treatments for gonorrhea in the most recent guidelines that have just been issued in 2021, if I'm correct. Thank you, and over to you.
I have them here. I can paste them in the the chat. Yeah.
Back to you, Benedict. Sorry.
No. Thank you. That's very very useful. So what's done in some setting is you do the urine test and PCR, and if it's positive, you do the culture. But this is all associated with logistical challenges. As I said, important is that these patients are treated and not sent home without treatment. Yeah.
Okay, thank you. So there is another question. Please present this. So it's from Ria, from the Regional Referral Hospital in East Nusa Tenggara. Is it possible to create regional antibiogram? And is that effective for empiric treatment at regional level? As local antibiogram in hospital level alone might be unrepresentative, since the patient come to hospital probably have already had antibiotic in a primary health center, small hospital, or community doctor.
So yes, it is entirely possible to do regional antibiograms. As always, when you aggregate data, you have to be very careful that you really what you aggregate, right? And as I mentioned before, probably you have to distinguish somehow the community acquired from the hospital acquired samples, because the local epidemiology of resistance in the hospital may be very different, right? If you have an outbreak with multi-drug resistant organisms in some settings, this may completely then shift the entire results. And you know, the hospitals have different sizes, etc. So I think it is possible. Just be careful what you aggregate and that you have additional information. I would say that it makes most sense if you are able to differentiate community acquired from hospitals acquired infection. Knowing what is going on in other hospitals is always very important, because multi-drug resistant organisms tend not to stay limited to one hospital. They are transmitted between hospitals. So that's also important. So yeah, to summarize, feasible, but be careful how you do it.
Thank you. So any other question? So there is no more question, and actually we have 7 minutes only.
I talked too fast.
No, it's okay. So thank you very much for your excellent presentation and also very fruitful discussion. So I think this is still the first time we know about the book. So I think there should be another seminar like this, Bu Mukta, because this book is very good and I think very useful for us in Indonesia, where the facility of microbiology laboratory are limited. So that's why we can use this as a reference. But of course, again, we need to be very careful in interpreting the book. So I mean the use of this guideline. So, and we need, of course, more information deeper about this, how to use this book, I think. Yeah. And another thing is we always say to our colleagues that antibiogram is very useful, and we have to make our own antibiogram in each hospital. But you have already mentioned that it is difficult, and I realized this, that we need to inform the use of this antibiogram correctly, because as you said that most of the patient come to admitted to hospital usually has already treated with antibiotics. So that's why it is not really, maybe it is not really the pathogen that we have to treat. Yeah, so I think this is the end of our, I'm sorry. Okay, so there is still one question.
Yes, if
Okay, Ibu Effie, please. Can you ask directly, please?
Yes. Excuse me, can you hear my voice?
Yes.
Yes.
Yes. Thank you so much for the opportunity. My name is Holly. I'm a dermatovenerologist from Karyadi Hospital, Semarang. Thank you for sending the guidance for a sexually transmitted infection from the WHO, because in Karyadi Hospital, Semarang, so far we use the guidance from CDC, which is at the first glance, I don't think that it's too much difference, but from CDC, the guidance doesn't underline the need to do the culture first before we give the antibiotic treatment? That's my first question, because which one should we use? Is it better if we use the guidance from CDC or from WHO? And then my second question is, because of my job as a dermatologist, we use a lot of topical antibiotics like fusidic acid, gentamicin. And in Western world, I understand that there is culture for topical antibiotics, but in Indonesia, it hasn't yet available. So can you give me advice on how to give the topical antibiotic therapy for my patient, because we cannot do the culture for topical antibiotics here.
Yeah.
Thank you so much for the opportunity given to me. It is a very good webinar. I'm waiting for the advice. Thank you.
Thank you very much for the good question. So I have to declare a conflict of interest, right? I work here for WHO. So if you ask me, should you use CDC or WHO guidelines, you can anticipate my answer. So definitely WHO guidelines. Now, but without joking, so the US guidelines, not just from the CDC, but also from the Infectious Disease Society of America, are very often very well done. But they do not take the same perspective as WHO guidelines. There is no global perspective. It's usually focused on the American situation, American healthcare system, which at sometimes maybe pose less emphasis on antibiotic stewardship aspects. So I would say that in most situations, the WHO guidelines are preferable compared to the CDC guidelines, except when you are in the United States. So that's the first answer. And the second question was about the topical antibiotics. So topical antibiotics is a difficult issue. It's actually recommended in the antibiotic book because it's on the essential medicines list. Mupirocin for impetigo, non-bolus impetigo, is an option. I don't think you need necessarily a culture. There are also topical antibiotics for some of the eye infections. But in general, I would say that the evidence for the effectiveness of topical antibiotics often is relatively low. And maybe we have a tendency to overestimate the efficacy compared to systemic antibiotics, because the penetration and diffusion is probably often limited. So I think there may be limited indications. I mentioned the impetigo. Otherwise, I think it probably rather limited the niche where topical antibiotics really have a significant benefit for the patient.
Okay, thank you so much for your answer. I really appreciate it. We're from Karyadi Hospital Semarang.
Thank you
Very much.
So thank you very much, Dr. Benedict, for your very excellent and valuable presentation. And I hope this is very useful as well for all clinicians and also other profession here in Indonesia. Little bit I want to say in Indonesian. So Bapak Ibu yang saya hormati, saya rasa presentasi yang disampaikan oleh Dr. Benedict ini sangat bermanfaat untuk kita. Dan tentu saja kita di Indonesia memiliki permasalahan yang spesifik yang perlu kita pertimbangkan selanjutnya di dalam menginterpretasi buku ini. Dan tentu ini adalah suatu referensi yang sangat baik untuk kita, sambil kita juga mencoba untuk menyusun mungkin pedoman yang sesuai dengan keadaan di Indonesia. Mungkin ada beberapa obat yang tidak tersedia sesuai dengan formularium yang ada atau tersedia di Indonesia, sehingga tentu kita harus menyesuaikannya. Ya, mudah-mudahan waktu kita ini sangat bermanfaat untuk kita semua, terutama di dalam memberikan pelayanan yang terbaik untuk pasien-pasien kita. So again, thank you very much, Dr. Benedict, and also Dr. Mukta for your idea to conduct this online seminar. So do you want to have something to say as a closing remark, Dr. Mukta?
Yeah.
Dr. Benedict, so please.
Sorry.
No, it's okay.
I just want to thank you very much for the opportunity, and I just want to tell you also that any feedback you have on the book, what are the issues that need to be addressed, is really key to us. So if you have comments, do not hesitate to send it to us. Sorry, over to you, Mukta. I understood Hutna. So.
Okay. Thank you.
I just want to join Ibu Anis and all our colleagues here in Indonesia, Benedict, to thank you for making the time to talk to us. But I also want to thank you for sharing the final draft of this document with us, which we are translating now into Bahasa Indonesia. And once we have it translated into Bahasa Indonesia, we will be working with the Ministry of Health, as well as we'll be guided by the AWaRe committee on how best to disseminate and share this information. We will also be trying to turn this into an app, which can be available for everybody. So this meeting today, this seminar today, is just the beginning of a process. And we really look forward to your feedback on how Indonesia can utilize this new resource better, and what you think are some of the needs. So please feel free to communicate with us and share with us your ideas on what is the best way to disseminate this information and to socialize everybody on the use of this information. So with that, once again, thank you, Benedict. And I'm very, very grateful to Ibu Anis again for making the time today to take us through this, and to all my WHO colleagues who worked very hard to put together this webinar. So thank you once again, and bye-bye.
Thank you.
Thank you.
Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum.
Thank you, Dr. Benedict.
Thank you. Bye.
Bye, Benedict.